Do you think neurologists would start recommending cladribine to treat primary progressive MS?
Well, we have been using it now for several years. So we've had what we call a compassionate off-label use. But again, there's lots of issues around off-label prescribing. It's allowed. We as an individual clinician can easily prescribe anything we want, and we are protected by about the GMC's got legislation in place, well, guidelines in place. We as clinicians can prescribe anything that's licensed, it's not a problem. The issue at a systems level is not quite clear. So when there are therapies available that are licensed within a regulatory framework it's not ideal for healthcare systems to promote off-label prescribing when there's a labelled one. So it can happen at a small individual level, but that then is going to require local champions. Yeah. So that'll create a lot of variation and a lot of inequity. So people with primary progressive disease coming to our institution and get treated. People going to others where they're not prepared to do that won't get treated. So, whereas if ocrelizumab was licensed, everybody will have access to treatment, and I think that's more important than the inequity associated with institutions using off-label therapies. There's another one we could potentially use is rituximab, which is kind of the forerunner of ocrelizumab. In other countries and a lot of healthcare systems now are allowing rituximab to be used. But again, it's the same issues. And rituximab is a little bit more expensive than cladribine. And so the question then, who pays for it? Because unless NHS England pays for it, which is a high-cost drug, you probably find individual healthcare trusts, individual NHS hospitals may not be prepared to pay for it. So that, again, it'll create a lot of variation. And one of the principles of the NHS is, it should be equitable. And so we are undermining equity. That's what we're undermining.